Today we are discussing examination of cardiovascular system. We will be discussing under different heads: examination of pulse, blood pressure, JVP, and then inspection, palpation, percussion, auscultation. Today's session we are discussing basically these 7 aspects of cardiovascular system examination. Let us start with the examination of pulse. As the left ventricle ejects blood through aorta, a pressure wave is produced and it's transmitted to the periphery, which we call as pulse. When we have to examine pulse, commonly we look for radial pulse, brachial pulse, carotid pulse, superficial temporal, femoral, popliteal, dorsalis pedis, and posterior tibial. How to identify these blood vessels? The radial artery is commonly felt just medial to the radius, can easily be felt. When we slightly pronate and flex the wrist a bit, the wrist will be very much relaxed and you can easily feel the radial pulse. The brachial pulse is identified just medial to the tendon of the biceps muscle. If there is any difficulty, the usual pattern is to follow the middle finger, the longest finger, and it goes and touches brachial artery. That's how it is identified. Coming to the carotid, you commonly feel at the level of thyroid cartilage medial to the sternomastoid. And femoral is commonly felt just at the mid-inguinal point. And popliteal artery is felt by flexing the knee a bit and palpating in the popliteal fossa. And dorsalis pedis can easily be felt when you keep your fingers between the big toe and second toe and go proximally, and in between the metatarsals you feel the dorsalis pedis. And just behind the medial malleolus you get posterior tibial artery. So once you know how to identify these blood vessels, the superficial temporal artery is just in front and above the ear, can be easily felt, and it will be commonly tender in cases of giant cell arteritis or temporal arteritis. Now when we examine the pulse, the first thing is you look at the rate of the pulse. Rate means the number of pulse per minute. That's the definition of rate. And the unit of measurement is number of pulse per minute. So as we discussed earlier, you position the patient's limb such a way that you support the wrist, flex the wrist a bit, and in this semi-pronated position, you can easily feel with the 3 fingers of your left hand. And you can count in your watch what is the pulse rate. At least 30 seconds we have to count and multiply by 2 and make it 1 minute. Commonly we find heart rate is between 60 to 90. Below 60 call as bradycardia, and above 100 you call it as tachycardia. Now if a pulse is absent, what does it mean to us? It means that there is no blood flow through that blood vessel, and it may be acute process or a chronic process. If it's acute process, the part distal to that vessel will be cold, and if it's chronic, aberrant regeneration, collaterals develop, and you find the limb is warm but the pulse is not felt. So if you find the pulse rate is in the normal range, that does not necessarily mean the patient is having sinus rhythm. Sometimes situations like atrial flutter, where you find there's a fixed block 1:4, you may find that pulse is felt normal rate, but there is a abnormal tachyarrhythmia going on. Now coming to the rhythm. Rhythm is defined as regularity with which one pulse follows the other. That means interval between the pulses. Commonly we describe the pulse as regular or irregular. Regular pulse is commonly seen when the heartbeat occurs from the sinus node. Also, when there is a complete heart block, you may find the rhythm, the pulse, you will be looking like regular. Again, atrial flutter with variable block, you may find rhythm appears regular, but there is some arrhythmia going on. But When you find the rhythm is slightly irregular, heartbeats become irregular, that does not necessarily mean there is some arrhythmia. There can be respiratory variation of the rhythm, that's called as sinus arrhythmia, where again it's a normal phenomenon and it is nothing abnormal. When the pulse is irregular, you think whether it is regularly irregular or irregularly irregular. Regularly irregular pulse may be because of bigeminy or some ectopics coming up. Irregular, commonest cause is again multiple ventricular premature contractions or atrial fibrillation. When the pulse is irregular, automatically we will be looking for pulsus deficit. Pulsus deficit is a situation where you check the pulse of the person simultaneously for 1 minute. You are checking for the rate of the heart by auscultation. If the difference between the two is more than 10, you call it as pulsus deficit, and that indicates possibly this patient is having atrial fibrillation. The third thing you look at the pulse is the volume of the pulse. Volume of the pulse is the amplitude of movement of the vessel wall as a pulse wave is passing through. It is the amplitude of movement of vessel wall as the pulse wave is passing through. It depends upon the blood ejected from the heart. So it depends upon the stroke volume and the compliance of the blood vessel. If the stroke volume is very less, as in aortic stenosis, hypovolemia, you will find it's a very low volume pulse. On the other hand, if the patient's as age advances, compliance decreases, and it may cause wide pulse pressure, and you may find that the pulse volume is more. So it's very important to check for the volume of the pulse. It may so happen that the pulse volume keep on changing. For example, in atrial fibrillation, one normal beat may eject quite good amount of blood to the aorta. You get high volume pulse. Next heartbeat may contain very little blood, so that may not be enough to produce a pulse wave. That's how you get pulse deficit sometimes. Because same reason, in atrial fibrillation, the diastolic period be variable. Each time during diastole, the amount of blood ejected will be different, and that produces variable amount of pulse volume. So pulse volume keep on changing. Now there are other scenarios where pulse volume changes. One is pulses alternance, where when you feel the radial pulse, you find alternate pulse is of low volume, alternate pulse is of high volume, but rhythm is regular. So pulses alternate regular rhythm, but volume is keeping on changing. In case of pulsus paradoxus, when you palpate the large artery like brachial, or when you palpate a major artery like a femoral artery, when the patient is taking spontaneous breathing, you find during inspiration, pulse volume comes down. So volume can be changed in different scenarios, and volume basically represents pulse pressure, that means difference between systolic and diastolic blood pressure. So after the volume, we are going to the character of the pulse. What is the character? What is meant by character? When a pulse wave is passing through, there will be rise of the pulse, there will be plateau and the fall, and that can be felt with your fingertips over major vessels or even radial vessels, and this contour is called as pulse character. So the normal pulse character has got a rapid upstroke, there's a brief plateau, and there is a less steep downslope. This is the pattern of normal arterial pulse. When you record in the laboratory, you may be able to find out all the waves of the pulse, but bedside you can have only one pulse. There is a upstroke, downstroke, and a plateau. And where are you looking for the pulse characters? There are 5 abnormal characters of the pulse. They are all looked at various different places. One example is anacrotic pulse, otherwise called a slow rising pulse, and this is a situation seen in aortic stenosis. Obviously, whenever there is aortic valve or aorta is involved, the vessel look for the character is preferably the carotid. So you look for the carotid pulse, and the site where you look for carotid pulse is at the level of thyroid cartilage. If you palpate higher above, you may touch the carotid sinus, which is no good. If you go lower down, you may not be able to palpate properly. Also, when you are palpating the right side, you palpate with your left thumb, and when you are palpating with the left side, you use your right hand. The carotid is never felt like this as you are throttling a person. Also, never feel both carotid simultaneously. So, in slow rising pulse or anacrotic pulse, what you find is when you palpate, the pulse volume is very low, number one. The upstroke is very slow and plateau is sustained for some time, and then you have downstroke. And the last part, pulse pressure is very narrow. So there are many components for slow rising pulse: low volume pulse, slow upstroke, sustained, there is no definite peak, it's a plateau, and there is a slow downstroke. So this is what is called as slow rising pulse or anacrotic pulse. Simultaneously, you may be able to see, hear or feel like a purring of a cat, and that is the carotid thrill or shudder. So that can be felt sometimes when there is a carotid stenosis. Also, if there is aortic stenosis, the murmur may be conducted to carotid, you may feel as a thrill. Whenever there is a murmur, you cannot distinguish between aortic stenosis murmur and carotid bruit. So you don't commit on carotid bruit, you stop saying it is a murmur from the heart. If there is no murmur, what you feel as a thrill or as a murmur, the carotid is a carotid bruit. The second pulse character you are looking for is collapsing pulse. Collapsing pulse is best felt peripherally, that too or the radial. When you palpate the radial with the palm of your hand, preferably like this, and whatever adenindo. Do you have any pain here? No. So the patient is not having any pain in the shoulder, so I can easily lift it, and suddenly I will be lifting like this, and what I am looking for is collapsing pulse. What is meant by collapsing pulse? Just like the slow rising pulse, here the volume is very high and the upstroke is very steep and there is no plateau and suddenly drops. This tells us there is a wide pulse pressure for collapsing pulse. Basic mechanism is, in collapsing pulse, blood leaks out from the left side to right side. For example, blood from the aorta is leaking back to left ventricle, aortic regurgitation. Blood is leaking from the aorta to pulmonary artery in case of PDA. Blood is leaking from arterial side, venous side. In a fistula, you get this type of collapsing pulse. There are causes for non-cardiac causes for collapsing pulse, like thyrotoxicosis, Paget's disease, beriberi, and so on. But commonly, it is the cardiac causes that produces collapsing pulse. So, radial artery is the preferred site for collapsing pulse. Now we are going to look for what's called as bispheriens pulse. As the term bis means two, this is a type of pulse commonly seen when there is a combination of aortic stenosis and aortic regurgitation. Rarely it can occur in isolated aortic regurgitation as well. Either you can feel the carotid or you can feel the biceps. You may use your thumb or you may use your 3 fingers and press on the biceps muscle till you obliterate the brachial artery, and slowly you release it. Either when you press down or when you release, you may find 2 peaks. The 2 peaks are anacrotic wave and the percussion wave. Please note, both these waves are in systole and not in diastole. So when the pulse is regular, if you get 2 peaks, it is not bigeminy. If you get 2 peaks, is it dicrotic pulse, again where there is a 2 peak, or is it a bispheriens pulse? In dicrotic pulse, one wave is in systole, other one is in diastole, whereas bispherian pulse, both the waves are in systole, and it gives very good clue that this is a combination of 2 diseases together. Now we go to the examination of pulses alternans. Pulse alternans can be felt at the level of the radius. You palpate carefully, you can see alternate pulse is large volume, alternate pulse is low volume. So high volume, low volume pulse alternates. Unlike in a bigeminy, here it is a regular rhythm. regular rhythm. And when you take the blood pressure with a sphygmomanometer or a mercury anerometer, you may find that you are able to hear the Korotko sounds corresponding to the high volume pulses alone. As you decrease the mercury column, gradually at one particular point you will start hearing Korotko sound from the low volume pulse also. In other words, when you lower down the mercury column, suddenly the Korotko sounds doubles, and this is what is called as pulses alternans, and that indicates patient is in left heart failure, left ventricular failure. The last abnormal pulse is pulses paradoxes. Paradox means something not expected. So when you take deep breath, commonly the blood going to the left heart becomes less, cardiac output becomes less, blood pressure comes down. The paradox is at that time during inspiration, pulse rate goes up. So pulse rate going up, blood pressure coming down is the paradox here. That's what Kussmaul described as paradoxical pulse. So this is easily felt by simply palpating the femoral artery, as he said, mid-inguinal point between the anterior sphenic spine and pubic tubercle. And you don't ask the patient to take deep breath, just observe him, and during inspiration the pulse becomes almost non-palpable. This is the extreme form of pulses paradoxes, but minimal or rarely cases may be missed by this, where you use a sphygmomanometer and check the blood pressure, and in expiration you are able to hear the Korotko sound, and inspiration still down. Usually the difference between the blood pressure during expiration and inspiration is less than 10. When it is more than 10, you call it as pulses paradoxes. It can occur in constrictive pericarditis, pericardial tamponade, severe asthma. So there are different situations pulses paradoxes can occur. So there are two types of pulse characters where you may use the help of sphygmomanometer. One is pulses paradoxes, another one is pulses alternans. Now you are looking for what's called as a radiofemoral delay. What is my radiofemoral delay? I am palpating his radial artery, simultaneously I am palpating his femoral artery. You may find the femoral artery appears delayed compared to the radial artery. This classically occurs in what is called as coarctation of aorta, where you find a constriction has taken place by birth in the aorta distal to subclavian artery. So blood cannot go down to the descending aorta. Obviously, blood takes collaterals, and collaterals run a runabout course and comes back to the aorta through a curved route. Because the long distance it is to travel, the lower limb pulse will be appearing delayed. This is called as radiofemoral delay. You may also find sometimes you are suspecting diseases of the aorta or the major blood vessels. You have to check two radials simultaneously for radial delay. So commonly both radials appear simultaneously. If there is a radial delay, that means there is some obstruction on the way. Classically, in case of Takayasu disease, or there is embolism, or some procedure is done, you may find there is a delay between the two. So radial delay and radiofemoral delay. Now we have to check for the peripheral blood vessels. All the blood vessels have been checked. Now we have to look for vessel wall thickening. How do you look for vessel wall thickening? In a normal person, blood vessels are not palpable. When it becomes thickened, it can be rolled under your finger. For example, you take the radial artery, you put your 3 fingers here, you obliterate the blood vessel, and then with the middle finger, you roll it under your finger. So you put a ring finger, you obliterate the blood vessel, middle finger will be palpating the artery, and you may find it's cord-like thing if the vessel is thickened. Sometimes you may find beading-like appearance, which is suggestive of Monckeberg sclerosis. And another way to look for is palpate the brachial artery and roll it under your fingers. Commonly you cannot feel your brachial artery a separate cord, but if you find separate cord, that's again suggestive of a thickened blood vessel. The pulse of a person depends upon the amount of blood available for ejection, so blood volume. Depends upon the obstruction the blood is facing, peripheral vascular resistance and distensibility of the blood vessels. All these factors will decide what type of pulse character you feel commonly. Now, when you look at the carotid pulse, one important thing is sometimes you may get a jerky pulse, which is diagnostic of hypertrophic obstructive cardiomyopathy. You palpate the carotid starts coming just like a normal pulse. Suddenly it goes down because the left ventricular outlet obstruction, which is dynamic, suddenly obstructs the flow of blood. So suddenly it comes to stop and slowly it comes out. That's how you are feeling for the jerky pulse. Now, if you don't feel the carotid artery very well, but you are able to feel the brachial and the radial very well, the inference is possibly this patient is having aortic stenosis. In aortic stenosis, as the blood flows to the periphery, pulse is better felt than in the proximal vessels like this. So, coming to the peripheral pulses, we have to complete the examination by looking for dorsalis pedis, posterior tibial, popliteal, femoral, brachial, carotid and superficial temporal artery. So this will complete the examination of pulse. You are looking at you identify the blood vessel, you look for the common pulses we have already described, the rate, rhythm, volume, character, radiofemoral delay, radial delay in selected cases, and the other peripheral blood vessels and the thickening of the blood vessels wall. If a pulse is not palpable, what are we expected to do? That means there is no flow of blood through that blood vessel. If you don't have pulse in the lower limb, for example, right lower limb, what I will do? I will check for the popliteal, it is palpable. So what do I look for next? I look for the temperature of his two lower limbs and compare the two sides and find out up to what level the temperature is abnormal, coldness. Now I will look for hair distribution. If it's a chronic disease, we will expect the hair to be lost. I will look at the skin, is it atrophied or not. I will look at the nails, it's atrophied or not. Then I will be looking for whether the muscle mass is reduced by taking the measurement of the muscle. Obviously, I will be looking where is the block. So proximal vessel, popliteal and femoral will be checked at. If I don't get lower limb blood vessels, the possibilities are many. It may be a disease of the lower limb blood vessel like TAO. It may be an embolism, but commonly discussed hot topic like coarctation and something called Leriche syndrome, where there is a block at the level of bifurcation of the aorta. So, how to distinguish among these conditions? If it is Leriche syndrome, blood will be passing up to the bifurcation of the aorta. So, the blood is passing here. So, obstruction is lower down. So, you will be able to feel a aortic pulsation in the epigastrium. On the other hand, if the block is in the coarctation, blood will not be coming over here. You don't expect an epigastric pulsation. This is an important point to differentiate between the two. Also, you may get a bruit at the level of the bifurcation of aorta, at the level of umbilicus for Leriche syndrome, which may not be possible here. Also, you look for bruit in any blood vessel where there is obstruction of flow, and that is what will help us to localize where is the possible obstruction is. Thank you.